Thank you for joining my presentation on multi-drug resistant organisms in the ICU. My name is Terrence Shenfield and I am the co-owner of A&T Respiratory Lectures and a former education coordinator at a major trauma center in Newark, New Jersey. Because of the overuse of antibiotics in today's medical society, we have developed many different types of resistant organisms. Also, this is a time when pharmaceutical companies are not investing their hard-earned money into research protocols for new antibiotics. The problem is that pharmaceutical companies develop these new antibiotics, and within a short period of time, bacteria become resistant to it. So as a result of that, many pharmaceutical companies are not coming up with new antibiotics. The strategy currently is to use a combination of different antibiotics, but at this point, why would a pharmaceutical company invest money into developing a new antibiotic when shortly it becomes resistant? So this is becoming a problem for the patients, because a lot of patients, especially elderly patients in nursing homes and such, are resistant to many different antibiotics. So this lecture is going to be going into details of why organisms become resistant and what we can do to stop it. The sad fact is that close to 20% of all patients who are admitted to the ICU, who are in the ICU for greater than 24 hours, end up getting some form of nosocomial infection. This is a problem. A lot of these patients are, immunocompromised as it is. Their immune system is impacted due to their illness, and as a result of this, they become susceptible to pathogens that are harbored in many ICUs. So the goal is to use some prudent strategies to prevent the spread of infection, and that incurs that nurses, respiratory therapists, doctors all take these precautions not to spread these pathogens to the patients. So as we go along further into this presentation, you'll learn a lot more. Today's objectives will be describing what is a multi-drug resistant organism. We're going to be talking about the history of antibiotics and focusing on the abuse and misuse of antibiotics. We're going to talk about how do bacteria become resistant? How do these organisms actually go from being non-resistant to resistant? I'm going to also be talking about some simple tests such as the gram-negative and gram-positive to show the difference between them both. I'm going to talk about ways to control the spread of these organisms. And then, most importantly, I'm going to talk about strategies on prevention. What can you do to prevent these organisms from being harbored in the ICU, and what can you do to stop the spread of them? Very important. So what are multi-drug resistant organisms? There are many bacteria in the world. There's thousands of them, and not every one of them is pathogenic. And typically, when you have a pathogenic type of bacteria, such as Staphylococcus or Streptococcus type of infections, you could treat it with an antibiotic. The problem is, over time, certain organisms that responded very well to standard antibiotics become resistant. And I'll get into the reason how they become resistant a little bit further. But the problem with that is the antibiotics that we would normally use to treat these infections now can't treat these infections, and then this bacteria just grows and grows. Some common examples of multi-drug resistant organisms is MRSA. MRSA is basically a Staphylococcus infection that would normally be treated with methicillin, but now methicillin, which typically would kill it, doesn't work. So that's your MRSA infection. Another common infection is vancomycin. Vancomycin really is very good antibiotic to kill enterococci bacteria. But as a result of becoming resistant, we end up getting VRE. The real problem comes with ESBLs, which stands for extended spectrum beta-lactamase-producing endobacteria. Enterobacteria are they're gram-negative bacteria that typically cause respiratory infections. They could cause urinary tract infections, and these are typically bugs that are seen with a lot of patients in nursing homes, and especially the elderly. So, and the treatment for these type of bacteria, enterobacteria, is typically beta-lactam drugs such as penicillins, cephalosporins, carbapenems, fluoroquinolones. So all of these type of antibiotics would normally be used to kill this bacteria. But what happens now is that these bacteria built up some form of resistance. So this represents the #1 threat in hospitals, in nursing homes, in long-term care facilities, and that is ESBLs. And we'll get a little bit more into that. So the key point here is that there are bacteria that normally would be killed by standard antibiotics, but over time they build up resistance, and then these antibiotics become useless, and this was what causes really pathologic harm to the patient. So that is what multi-drug resistant organisms are. So let's talk about the history of bacteria. Bacteria have been around for billions of years. They are here for a long, long time, and they could continue to be here for a long, long time. There's fossil evidence showing that some of this bacteria has been around for over 3.5 billion years. They reproduce by a method called binary fission. And the thing about bacteria, if you put a bacteria in the right environment, they can reproduce. One bacteria can make 1 billion clones in 10 hours under the right conditions. Another thing about bacteria as a natural way of, surviving is they mutate. So when they mutate, antibiotics that would normally be used to kill them, when they mutate, the antibiotics become ineffective. And this is a natural process. Mutation is natural. It's for the survivability of the fit, and bacteria mutate naturally to survive. So that's a little history about where bacteria come from. So let's talk about a brief history of antibiotics. And I'm talking very brief, as of 1928. In 1928, Dr. Fleming produced penicillin from bread mold. The funny part about bread mold, and I don't know how true this whole thing is, but when I was younger and my mom's old school, and I had some kind of boil or infection on my hand or arm or whatever, it's not like I had a lot of these in my life, but I remember my mother taking bread with warm milk and then putting a bandage around my arm with this kind of contraption. And to tell you the truth, the next day it would draw all the pus out of that infection. I think I had this once in my life, but the bottom line, I don't even know why I'm telling you this, but in 1928, Dr. Fleming produced penicillin from bread mold. In the 1930s, Chain and Florey made it available to the medical community and patients. So now all of a sudden in the 1930s, they started using penicillin for all kinds of infections that came around. During the 1943s or the 1940s, penicillin became widely available by pharmaceutical companies. And then in 1945, Fleming, Chain, and Florey, they received a Nobel Prize for their work on penicillin. And how do you like this one? In 1969, the U.S. Surgeon General, which his name was William Stewart, said that infectious disease is a thing of the past and we should close the books on infectious disease. That is crazy, considering what's going on in the world right now with COVID. Infectious disease are here to stay. We are coming up with better technology and better medicines to treat them, but the fact is they're always going to be around. So in the 1940s, pharmaceutical companies mass-produced penicillin, and so many treatments were made available to patients who suffered from any kind of bacterial infection. And all of a sudden, there was problems. This is when multi-drug resistant organisms emerged. Right in the 1940s, just as they came up with penicillin, they all of a sudden started developing multi-drug resistant organisms. And you want to know why. Why do bacteria become resistant to antibiotics? And there are certain things, certain theories out there. Number one is Darwin's theory of survival of the fittest, which that theory is, bacteria, just like any other living organism, they have to mutate to survive. They have to thrive in various environments. And the truth is, just like animals, just like people, just like bacteria, the bacteria needs to mutate in order to survive. This way, if the antibiotic is given, they could just brush it off. The key point to this is mutation. Mutation is the key way that bacteria survive. Also, the bacteria have developed different systems. One is called destruction inactivation. Another system they have is called an efflux pump, and the other one is called genetic transfer. So I'm going to go over each and every one of these so that we go a little bit more detail on what causes a bacteria that was not multi-drug resistant, that was not resistant to a certain bacteria, to become resistant. What exactly occurs? So when you think about bacterial resistance, there are two major types. One is called intrinsic resistance, and the other one is called extrinsic resistance. When you think about intrinsic resistance, think about bacteria that have the genetic makeup that a certain antibiotic will not respond to them. So in other words, these bacteria have certain genes in them that if you give an antibiotic to them, they will just brush it off. It will not do a thing for them. The good news about intrinsic resistance is that it makes it very clear to physicians and clinicians what kind of antibiotic to use based upon what kind of bacterial infection. And this is really good because it's very predictable and you know what to order and what not to order. For example, intrinsic resistance with streptococci infections. Basically, streptococci infections are resistant to any kind of aminoglycoside, such as gentamicin and tobramycin. So what happens is, if a patient has a strep infection, you're certainly not going to give gentamicin or tobramycin because it's not going to work. And why doesn't it work? Because the bacteria itself, the streptococci bacteria, have the DNA that will fight off any kind of antibiotic that comes to them in regard to the class of gentamicin and tobramycin. Another example would be gram-negative bacilli that are all intrinsically resistant to vancomycin. So if someone has a gram-negative bacilli infection, you're certainly not going to give vancomycin because it won't work with them. So intrinsic resistance is kind of straightforward. The organism, the bacteria, have a certain genetic makeup that will fight off that bacteria, or no, will fight off that antibiotic, and as a result, it's kind of clear about exactly what you order for them. Now let's talk about extrinsic resistance. So let's talk about extrinsic resistance. First of all, I just wanted to give you a quick background how antibiotics work. Antibiotics work by, these are chemical agents that have a specific bacterial target on the organism. For example, certain antibiotics inhibit bacterial cell wall synthesis, other ones inhibit protein synthesis, and other ones handle nucleic acid replication. So these are the three pathways that typical antibiotics work. Now, in regard to extrinsic resistance, this means that the organism does not have the genetic ability to fight off an antibiotic. So what happens is, to survive, the organism has a change in their genetic composition. So in other words, their genes change, their chromosomes change. And they do this either through natural mutation or they do this by a very common method, which is the acquisition of genetic material. So I'll get a little bit more into both of them. In regard to a normal mutation, mutations are natural, and basically it's chromosomal DNA changes that occur naturally within any organism, but it doesn't happen very often. So in regard to natural mutations, they get changes in their chromosomal DNA, and as a result of that, the antibiotic doesn't work. An example of a natural mutation or chromosomal DNA changes is with Mycobacterium tuberculosis. That bacteria at one time used to be treated with isoniazid, but now it's not because it's built up resistance. One of the worst things to get is antibiotic resistance Mycobacterium tuberculosis, because it doesn't really treat, nothing really works for it. So that's an idea of either natural mutation. Now I'm going to talk a little bit more about the acquisition of genetic material, which is not a natural phenomena, but it's a way that bacteria survive. So another method that bacteria survive or become resistant to antibiotics is through the acquisition of new genetic material. In this case, it's plasmids. I'm sure you remember from your microbiology class the term plasmid. Basically, this is a little piece of DNA that could be transferred from one cell to another. So what does that mean? What this means is that you have a bacterial cell that can be killed by an antibiotic, and then you have another bacterial cell that is not killed by the antibiotic. What happens is little pieces of DNA from the cell that cannot be killed is automatically transferred into the other cell. So it's actually the piece of DNA moves from one cell to another, and then all of a sudden that one cell becomes resistant. It could be attached to a couple of different ways. Sometimes it could be attached to a virus. A virus can take a little piece of that DNA and just move it into a host cell. The problem with this, once this occurs, now that cell becomes resistant to antibiotics, and that could multiply and create other cells. So this is one method of where a cell acquires a little piece of DNA material, in this case a plasmid, and becomes resistant. Another method for the transmission of the genetic material from one bacteria to another that would make it resistant is actually what is called a transposon. A transposon, again, is a little snippet of DNA. It's smaller than a plasmid, but it actually, what it could do is it could inject into the DNA sequencing. So in other words, you have DNA sequencing of different types of chromosomes. So what happens is it snips in and it changes the genetic material for the cell, which actually makes it resistant to antibiotics. And the new cell, this cell again can replicate and create other cells, like I was telling you before, how cells can reproduce. And now all of a sudden you got a bunch of bacterial cells that are resistant to antibiotics. So this is a second way in which genetic material is transferred from one bacterial cell to another cell, resulting in resistance. So a final form of DNA snippets is called the integron. Integrons are these tiny, tiny DNA structures that incorporate into the genetic chromosomes of the bacteria. And there are numerous types of these type of bacteria that are involved with this type of resistance. Now, before we get into it, there's a class of antibiotics such as penicillin, cephalosporins, carbapenems, and these are called beta-lactam antibiotics. And the concept of beta-lactam is that there is a ring that is shaped with these antibiotics that make it very useful to fight off certain bacteria. But because of these integrons, they actually change the genetic makeup of certain cells. And what they do is once they change the genetic makeup of these cells produce what is known as beta-lactamase enzymes. Beta-lactamase enzymes are enzymes that actually destroy antibiotics such as penicillin, cephalosporins, and carbapenems. So the concept is when you have plasmid-mediated production of beta-lactamase enzymes, what that means is that these bacterial cells now produce this enzyme called beta-lactamase that can actually destroy the antibiotic. And this happens a lot with Staphylococcus infections. It also starts with E. coli and enterobacteria species. So these particular bacteria become resistant due to with the integrons, and then what they do is they produce these beta-lactamase enzymes that kill any kind of antibiotic that come into them, especially in the family of the penicillins. So that's the final one for the DNA. This is how these cells thrive. This is extrinsic resistance, and it all comes down to snippets of DNA through various methods. I wanted to show you a different way in which bacteria become resistant to antibiotics. And this is another common method is called antibiotic selective pressure. So what exactly is antibiotic selective pressure? For example, my brother is a diabetic, and as a result of being a diabetic, he had recurrent kidney infections throughout his life. As a result of getting these recurrent infections, he was given many times antibiotics to kill the infection. Now, years later, after getting all these antibiotics, he has become resistant to certain antibiotics to work with him for future kidney infections. So that is called antibiotic selective pressure. And let me give you a demonstration. For example, the blue cells here are bacteria, and they are, they could be very killed by a simple antibiotic. But notice that most of the cells are simple bacteria. But one of the cells right here is resistant, right? So you give this patient antibiotics, and what happens is it kills all the cells around, but it does not kill the resistant bacteria. Then through binary fission, that bacteria produces and multiplies, and what you're left with is a whole host of bacterial cells that are resistant to antibiotics. This is an example of how the overuse of antibiotics can impact the normal flora of the body, resulting in resistant organisms that don't respond to antibiotics. This is called antibiotic selective pressure, and that's how it works. So you might be wondering, how do these multi-drug resistant organisms get introduced into the hospital? There are some hospitals that have ICUs that there have been outbreaks of resistant organisms. And some of the causes are that they believe that many patients, elderly patients with a lot of comorbidities who are admitted from nursing home LTACs, they are harboring resistant organisms. So what they feel is because of selective pressure misuse of antibiotics, they have developed their resistance, similar to the story like my brother with the diabetes and the kidney infections. So they feel because these population are elderly, they're a little frail, they've been having repeated bouts of infections because of antibiotic misuse, they have developed selective pressure anti-resistance to antimicrobials. Also, they believe it's very common, they call this clonal dissemination. And they believe that certain types of resistant bacteria have originated over from Europe, Spain in particular. And what happens is, this is a small world. People are traveling from one country to another, and there was an intercontinental spread of certain pneumococcal pneumonia, type 23F, and also this other type called 19F. All of these clones came over, bacterial clones of resistant organisms came over from Europe. And so these are the most common ways that MDROs are introduced in a hospital setting. And because most of our patients who come in, unless you're trauma or, having a baby, most of it, you have some form of illness. And a lot of this comes from the elderly population in nursing home and LTACs and so on. As I was mentioning earlier, a lot of pharmaceutical companies do not want to invest millions of dollars into a research study to create a new antibiotic, because as soon as that antibiotic comes out, they have a resistant organism. And I just wanted to show you the development of resistance to newly introduced antimicrobials over the years. For example, penicillin was approved in 1943. And the first form of resistance came out in 1940. Streptomycin came out in 1947. Same year you have the first reported resistance. Methicillin came out in 1960. 1 year later, you get resistance. Vancomycin, which had the best run, came out in 1972. But by 1987, there was resistant bacteria. So the point is, there are all of these antibiotics which are good antibiotics, but within a short period of time, because of misuse of antibiotics, because of genetic transfers of antibiotics, because of natural mutations of antibiotics, these bacteria become resistant at this time and nothing works. So that's why pharmaceutical companies don't want to invest a lot of money in this. So as you probably know, there are different types of bacteria out there, and one of the major classifications of bacteria is gram-positive and gram-negative. And it's a really simple way to determine what kind of bacteria you're talking about, and they do this by offering what is known as a gram stain. A gram stain is a dye that they put on top of a culture of cells, and based upon how the dye is absorbed into the cell membrane, you could determine whether it's a gram-positive organism or a gram-negative organism. Typically, gram-positive organisms are much easier to treat than gram-negative organisms. Most resistant organisms out there are gram-negative, and they actually present the bigger problem to patients. So in regard to the staining color, gram-positive organisms typically stain purple or blue in color, where gram-negative stain pink, red in color. And I'm going to get into a little bit different types of organisms and how they change, how they look under a microscope. But this is like a very old method to determine if it's gram-positive, gram-negative, which actually gives the doctor a better opportunity to know what kind of antibiotic to treat the patient with. Way before we have PCRs, this is the way they used to do it. So let's get a little bit into gram-positive organisms. As I mentioned before, the outer membrane of a gram-positive bacterial cell will normally take on the color of dark blue or violet. The image on the right shows you exactly what it would look like. Most pathogens in humans are gram-positive organisms. And they also, another differentiation is they're used by the shape of the bacterial cell. Some are called bacilli, which are sort of columnar in shape. Some are called cocci, which are basically spherical in shape. An example of a gram-positive organism that is round in shape is Streptococcus and Staphylococcus. So, based upon the gram stain, based upon the shape of the cell, you could almost identify what kind of organism it is. I mean, this is like real basic stuff, but it works. So let me get a little bit more about gram-negative organisms. So let's get on the topic of gram-negative bacteria. As we mentioned earlier, gram-negative bacteria will stain with a red or pink color. The color on the right is an example of what it will be. And the difference between a gram-positive organism and gram-negative is that the gram-negative organism has an additional cytoplasmic membrane to it as compared to the gram-positive organism. Sometimes that's why they believe that gram-negative organisms are harder to treat because of that cytoplasmic membrane. There is a whole host of many different type of bacteria that cause illness in patients. Klebsiella pneumonia, Pseudomonas, Escherichia coli, Acinetobacter. With these particular species of bacteria, all of them can cause harm. And they also could be resistant organisms too. In other words, Klebsiella would normally respond to an antibiotic, but if it's resistant, it may not respond. Some very common nosocomial infections in regard to gram-negative bacteria are Acinetobacter. Acinetobacter, when I was working at our hospital, that was the most common pathogen, gram-negative pathogen, for cases of ventilator-associated pneumonia. Also, it could cause meningitis. So these are the types of bacteria that can cause harm to the patient. They are gram-negative, and we're just talking a little bit about the staining ability of these particular bacteria. So now that we have a basic understanding of gram-positive organisms, gram-negative organisms, we know a little bit about how bacteria becomes resistant to antibiotics, either through natural selection, either through overuse of antibiotics, or either use of transmission of genetic particles from one organism to another. Let's talk about some of the most common organisms we see in the hospital that cause illness. You know, we all know from gram-positive, we have MRSA, we have VRE, and we have C. diff. From the gram-negatives, we have ESBLs, which are extended spectrum beta-lactamase-producing enterobacteria. And then we have also what is known as CRE, carbapenem-resistant enterobacteria. So these particular classes of organisms, gram-positive, gram-negatives, are what we mostly see in a hospital setting. And I'm going to get a little bit more detail about each type. So let's talk about MRSA, multi-resistant Staphylococcus aureus. It's a gram-positive organism that normally you mostly see on skin infections, but it can go in your blood and make you septic. The typical, it stains pink, purple in color. It also, as you can see from the image on the right, it's a topical infection. And I got some more information on MRSA. Pretty nasty. I looked up some information on MRSA, and the most current information I could find that would go over some stats was from 2019. I know I'm a little dated, but roughly this is what I found. Typically, there are about 119,000 cases reported each year, resulting in about approximately 20,000 deaths. When I first started working in respiratory therapy, we used to have MRSA infections all the time. Now, I started back in 1992, and during the 90s and early 2000, we used to see so many MRSA infections, but we've gotten better with it. From 2005 to 2011, there was a 31% drop of MRSA infections, and I think one of the biggest reasons for the drop is that we identified patients who have it, and we actually segregated them in the ICU. So we had a gown up, infection, PPE processes, and as a result, the number of cases have dropped. Typically, around 2.4% of all patients contacted MRSA in a hospital. There's some saying that MRSA infections increases the average hospital stay by 6 days. And a very important part here is that they say approximately a third of the healthy people in the population are colonized with Staph aureus, but we really are healthy and we're asymptomatic. But then they also say that approximately 1% of the above are colonized with MRSA. So there's a certain population that are colonized with MRSA infections, but they are asymptomatic. And once they get older, you have to figure that if they become immunocompromised, that MRSA could come to the surface. So the bottom line is, us as healthcare workers, I don't know, I was looking for some stats on what percent of healthcare workers are actually colonized with MRSA, because I worked with many MRSA patients and I've never really been tested for MRSA. I'm asymptomatic. I don't even know if I have it. So, but I imagine healthcare workers have probably a higher percentage. I heard some information that approximately 5% of us are colonized with MRSA, but because our immune system is strong, we really don't get sick from it. So I don't know, but MRSA infections are declining in a hospital setting, and I think it's due to a good infection control practices that we do. MRSA infections are really not sensitive to penicillin-based drugs such as methicillin, amoxicillin, penicillin, and so on. It normally lives on our skin. That's the normal flora of our skin, our nose, and also our genitals. It may cause infection if it enters the body. There are certain patients who end up getting septic from it. It's very contagious. So really it's from person-to-person contact. And the treatment for MRSA is typically vancomycin. That seems to be the drug that works best for MRSA infections. Vancomycin-resistant enterococci, VRE. We all have heard of it. And like I said, back when I was a therapist in the 90s and early 2000s, we used to have a significant amount of VRE infections. And basically, enterococci are bacteria that are normally present in the intestinal tract of all people. You and I have it right this second. It's part of our normal flora. Vancomycin is typically the drug of choice to kill enterococci infections. But vancomycin over the years has become resistant to this type of infection. People who are in good health are really not at risk for VRE, but healthcare workers are at risk. It's a very contagious bacteria. It could stay on inanimate objects for a long period of time, like ventilator knobs, door knobs, window shades, light switches, oxygen flow meters. All of those can actually keep a VRE infection on it for up to 7 days. I even heard longer. Vulnerable populations are children, the elderly, and those who are immunocompromised. So VRE infections are, again, decreasing. They're not as high as they used to be, but they still are around, and that's a little bit about those. When I worked as a respiratory therapist at my hospital, we had a lot of TB patients come in from the community. We also had patients who had TB and also HIV at the same time. The problem with this population is that when they have resistant tuberculosis, commonly known as extensively drug-resistant tuberculosis, XDR-TB, basically this organism has developed the ability to fight off any kind of antibiotic or treatment that would normally treat it. So what happens is isoniazid, rifampicin, fluoroquinolones, nothing really works with this particular organism. And if it does work, you need to keep this treatment program up to 2 years. A normal treatment program for TB was approximately 6 months of oral antibiotics. But you have to be compliant for 6 months. If you happen to have extensively drug-resistant tuberculosis, you need to do this treatment option for 2 years. The likelihood of you being compliant for 2 years is very low. So the likelihood of you spreading this organism with other patients or other people is really high. So this is another drug-resistant tuberculosis type, and it become resistant through the same mechanisms I told you about. Now this is a bad bug. It's called extended spectrum beta-lactamase-producing enterobacteria, or commonly known as ESBLs. Remember, beta-lactamase enzymes are produced by some bacteria that will be resistant to any kind of beta-lactam antibiotics, such as penicillin, carbapenem, cephalosporins. So basically, these bacteria that actually produce this enzyme, beta-lactamase enzyme, will destroy the antibiotics such as penicillin, carbapenem, and so on. So the way it does it, most of these antibiotics have what is known as a beta-lactam ring, and this enzyme destroys this ring, so it makes these antibiotics useless. So enterobacteria that produce these enzymes are resistant and very bad bugs. I'll get a little bit more into it. So a little bit more about these. Most of these organisms are gram-negative and rod-shaped. They are normally found in the normal gut flora in our intestines. The problem is, if they get into your bloodstream, if you happen to get septic from these particular organisms, the mortality rate is 60%. It's spread by fecal matter, and the most common type of species that actually produce this beta-lactamase enzyme are E. coli, Klebsiella, Pseudomonas, and Salmonella. So you can have any of these organisms. They all produce this beta-lactamase enzyme, which makes antibiotics fruitless. It doesn't work with them. So these patients have a high degree of mortality. How about Clostridium difficile, or C. diff? C. diff is a gram-positive bacteria. It is typically found in hospital patients, especially those patients who have large amounts of antibiotics. The problem with C. diff is if a patient has some kind of a bacterial infection and the physician orders antibiotics, the antibiotics kill all of the good bacteria that is part of our intestinal tract. The resulting fact is that the patients get C. diff, and the C. diff bacteria multiplies. When you get this infection, you get diarrhea, you may get toxic megacolon, you may get colitis, and also if it goes into the blood, you could get septic and die. C. diff is a spore-forming organism. Basically, what that means is that you cannot use alcohol-based hand cleaners. You have to use soap and water. The best thing to do with these patients is probably not give them so many antibiotics that you kill the normal flora in their intestinal tract. So C. diff is a problem, and now there is also C. diff resistant organisms too, which could really potentially, lead to sepsis and death. So this is another organisms to watch too. The CDC came up with some guidelines for reducing multi-drug resistant organisms, and it consists of a few different steps. First of all, you need to implement administrative measures. What do I mean by administrative measures? When someone comes up into the emergency room and they have a fever and they have a history of resistance from previous admissions, maybe you should put them in the isolation. Maybe you should give them a single room. Maybe you should have negative pressure. So the point is this: it's up to a hospital administration to actually set up guidelines that could protect the healthcare worker, you and me, as well as the patient. Also, you need to watch and make sure that they're doing what they say they are doing. So you have to monitor that all these controls are put in place. The second thing you could do is education. I've worked in a hospital setting, and when I first put this presentation together, there was no education on multi-drug resistant organism. I came up with one in my own department, so I actually used this PowerPoint to educate my staff. So understanding what multi-drug resistant organisms are, how they come around, how to prevent them is really important. Also, judicious antimicrobial use. Now, I know that doesn't fall under our realm as respiratory therapists and nurses, but when you really think about it, the doctors need to really identify what kind of organism there is, and then use a narrow spectrum antibiotic to treat that organism, and also not treat them forever with these antibiotics. Other ways you could do is through surveillance. You could actually do infection control precautions to prevent transmissions, and you could do environmental measures. So there's so many different things to do to prevent the spread of infections, especially these multi-drug resistant organisms. So I'm going to go a little bit more detail in the next slide. So I highlighted some methods on the previous slide, but let me go a little bit more detail. To prevent multi-drug resistant organisms, the first thing you got to do is start off with the appropriate antibiotic use. First of all, you need to identify when a patient comes in with a bacterial infection, you have to identify what kind of bacteria it is, and maybe you have to do a culture and sensitivity to determine which antibiotic is best. So once you determine the antibiotic that kills that particular bacteria, that is the antibiotic you should give, and you should give it up to the full time. I've learned through some research, I don't have it here on the slide, but I'll tell you that there have been times throughout my history that I've had some kind of infection, bacterial infection, and I went to the doctor and they prescribed an antibiotic to me. The doctor told me to take the antibiotic for the next 10 days. So I take it for day 1, I take it for day 2. By day 3, I'm starting to feel better. By day 4, I'm 100% better. And by day 5, I feel like I don't need these antibiotics. Why should I take them for 5 more days? And I've learned through my research that I was kind of wrong. I could probably become resistant to that bacteria by doing that practice. So the point, why is that the case? Because if I take an antibiotic and it suppresses the bacterial count to a certain degree that I'm asymptomatic, but it's still in my system, that means under the right conditions, that bacteria could come back, and then I have to go on another bout of antibiotics. So my message to you is, if you ever get sick, if you ever need antibiotics, and they're telling you to take it for 7 days, even though you feel better day 4, take it for 7 days. It's really important. Another very important thing is when you have medical equipment. Medical equipment is reservoirs for bacterial infections. Catheters, ventilators, catheters all about sepsis. Ventilators, VAP. There's so many different things going on. So if you could remove any kind of medical equipment from the patient as soon as possible and clean it properly, that's really important. Also, prevention of transmission to patients. I could not tell you enough about hand hygiene. Hand hygiene means you wash your hands for 20 to 30 seconds under water, and you really get yourself clean. As I mentioned before, C. diff is spore forming, so you really can't use alcohol-based products. They've shown studies where alcohol-based products results in greater compliance of hand hygiene, where washing with soap and water, there's less compliance. The bottom line is you really need to wash your hands. You need to wash it for at least 20 to 30 seconds, and time is a very important factor. The longer you wash your hands, the more bacteria you're going to remove. So, these are simple strategies that you got to put in place. So another method to do is surveillance. What do I mean by surveillance? We used to have an infection control person come up to our ICU, sit at a monitor, in the corner of the ICU and then watch all of us wash our hands, or who's not washing it, who's gowning up and who's not gowning up. They might be a mole, but actually these are good things for the patients and yourself. Really, if people are not being watched on what they're doing, they cheat. And the point is you really have to do some surveillance and monitor the ICU patients and make sure that compliance is being done. Also, you really need to do some screening. If you suspect someone coming in who has a MRSA infection from a nursing home, isolate them. Put them in isolation, get some samples, get some blood samples, get some sputum samples and determine whether they are positive or negative. This is really important. Screening of patients when they come into your hospital setting is really, really important. Also, determine if your treatment or intervention practices are working. If you have a certain strategy, but you're still having big outbreaks of infections in your ICU, you have to rethink what you're doing. So surveillance and all these strategies are really important in reducing the spread of infection. Let me tell you about some CDC recommendations for ventilator-associated pneumonia. It is the second most common nosocomial infection, and it results in approximately 15% of all hospital-acquired infections of patients who are intubated. The incidence of VAP is anywhere from 9 to 70%, and it's based on the length of stay, the type of patient, and so on. Typically, it increases your ICU stay by several days, typically in anywhere from 1 to 3 weeks. The mortality is anywhere from 13 to 55%, and it adds its cost to the hospital, which are very tight times, of anywhere from $40,000 to $50,000 per stay. So if you could do any kind of VAP prevention strategies, do it. Typically, there got two different types of VAP. One is called early onset, which means that you acquired a VAP infection with less than 96 hours of intubation or ICU admission. So if you develop VAP within 96 hours of being intubated, most of the time it's community acquired. So that means you came in with some kind of respiratory infection. The typical pathogens involved with early onset VAP are Streptococcus, Haemophilus influenza, and also Streptococcus aureus. Basically, these are very antibiotic sensitive. What I mean by that, they're easy to treat. So if you have early onset VAP, less than 96 hours, and it's either strep or Haemophilus influenza or staph and aureus, you can be treated with antibiotics, which normally respond very well. And typically these are gram-positive organisms. Let's talk about late onset VAP. Late onset VAP, that means the patient's intubated, but after 96 hours of intubation, they develop a VAP infection. Typically, this is hospital acquired. So it doesn't come from the community, it comes from the hospital. The typical pathogens at this point, except for MRSA, are typically gram-negative organisms, Pseudomonas, Acinetobacter, Enterobacter. Basically, gram-negative organisms, except for the MRSA, which are very difficult to treat and also are antibiotic resistant. So if you have a late onset VAP, it came from the hospital and it could very likely be antibiotic resistant. So you have to be careful with this population. I'm sure you heard this 1,000 times. Some VAP prevention, head of bed 30%. Keep your head elevated. Do a sedation vacation, daily assessment. Make sure you wean them. If you could put them on non-invasive ventilation, that's the way to go. They got some new generation endotracheal tubes with continuous subglottic secretion drainage. They got oral tubes are better than nasal gastric tubes. If you could do an intubation, make sure it's oral rather than nasal. Again, aggressive oral hygiene, DV2 prophylaxis, and PUD prophylaxis. So these are the VAP prevention. I mean, that's a whole lecture in itself. But I just wanted to point out, VAP infections do occur, and we should do everything in our power to prevent them. I want to thank you all for joining my presentation. I have some references if you need them, and I hope you liked my little Jeopardy questions. I figured I'd reinforce the information you give, and I want to thank you very much for joining me. You all take care.